Good morning, good afternoon, good evening, and even good night at many places, dear colleagues all around the world. It's my great pleasure to welcome you to this special IANPHI webinar recognizing the remarkable achievements of the 2024 Recognition of Success contest winners. Today, we come together not only to celebrate innovation and impact across global networks, but also to spotlight the transformative power of collaboration and commitment in public health and the importance of the pivotal role being played by IANPHI. Each of the winning projects we will hear about today represents excellence in action, from strengthening mortality surveillance and pandemic preparedness to implementing academic reforms and deploying One Health approaches to manage complex outbreaks. These projects are a testament to the dedication and ingenuity of our national public health institutes across all 4 IANPHI regions: Africa, Asia, Europe, and Latin America. Let us use this time to learn, reflect, and inspire. But before we start, let me have some rules for the speakers in the audience. Each speaker is allocated 10 minutes. For all the participants, I would request that they should keep their mute function on during the presentation and their cameras off. Participants are free to comment, discuss, or write anything and the questions even in the chat box. We will be having a special question and answer session after the speaker's talks, and that would be the time you can raise your hand. And for the information of everyone, the webinar is being recorded, and the recordings and the speaker's slides will be made available to the participants after the webinar. Now, before I move on to my elite speakers, myself, I am Professor Amir Kram. I'm currently the Vice President of IANPHI, and it's a privilege to host today's very important function. So to start with, our first speaker is Celso Maniene, who is the Head of Service and Surveillance at INS Mozambique, and his focus area is transition from Countrywide Mortality Surveillance for Action, COMSA, to Community Health and Vital Event Surveillance System, SIS-COVE. Over to you, Celso.
Thank you, Professor. So, let me share my presentation. So I hope you can see my slides now.
Yeah, we can see it.
Okay, so thank you. Good morning, good afternoon, everyone, wherever you are. My name is Celso Monjane, has mentioned it, and I am from Mozambique National Public Health Institute of Mozambique, call it INS in Portuguese. And I will be talking about an example or establishing the countrywide mortality surveillance for action, which was called COMSA, and the transition to community health and vital event surveillance system, also called SIS-COVE, and doing that on behalf of all COMSA or SIS-COVE team from Mozambique. So first, I would say that in Africa, many countries, including Mozambique, is a big challenge to have system for notifying and monitoring death continuously, and including the causes of death. One of the most important example is the CRVS, which we can call as a gold standard for civil registration and vital event monitoring. But in most of our countries, so this is example of Mozambique, only 10% of deaths are being covered by the CRVS system. So this is far from what we can consider as the main important system for us. We have our national health system covering around 60% in terms of health and well-being. But when we talk about the death, the number became very low, and we can see as a result here below that the health monitoring and information system only capture around 25 of deaths. So we mean that 75% of deaths are occurring outside of health facility, and there is no system to monitor. Besides, we have census and other surveys being conducted. Most of them have no causes of death, and they are not regular. So we are not sure when we can consider or to have this data being captured by this system. So in 2017, in Mozambique was established COMSA, or Countrywide Mortality Surveillance, being led firstly by government, so including INS, or National Public Health Institute, but also National Institute of Statistics, together conducting with assistance from Johns Hopkins University. And this was a proof of concept by being funded by Gates Foundation. And then the transition between 2020 and 2021 to SIS-COVE, which was more for country-led and to monitor not only causes of death, but also disease and potential for integration of disease surveillance and pseudo-surveillance. So COMSA was institutionalized as a surveillance system and owned and implemented by the government at the time. Then to respond to the need of the Minister of Health, Minister of Justice, and also National Public Health Institute and National Statistics of Statistics and other stakeholders, and clear the vision in terms of tasks for each of these institutions, including fundraising and data ownership. So between the COMSA implementation periods, I'm talking about 2017 to 2020, INS and National Statistic Office have been implementing together. The system has a primary stakeholder in terms of implementation, while Johns Hopkins University was a technical assistant to help both. But we also had other group, including the Minister of Health and Minister of Justice, has a secondary in terms of stakeholder, but also advising us how we can implement the study and monitoring the results. For that, we established a national advisor group, which was also the main advisor for us. So we had to present the results and the ongoing finding from the study each year for them, so that they can advise better for us. So after that, we transitioned to the SIS-COVE implementation, which is now being led by INS, or National Public Health Institute, and Johns Hopkins University is still the technical assistance who provide the technical assistance. So we work together with them in terms of technical assistance. So for now, we have Minister of Health, Minister of Justice, and also National Institute of Statistics as part of secondary implementers for the SIS-COVE data. So SIS-COVE is a simple registration system which rely on the geographic area selected randomly in each province to be representative at the national and provincial level, but also including some additional subnational level, like area of residence and so on. We decided to select a large number in terms of size of cluster, but also population. And we can see that when we compare with other surveys that have been conducted in Mozambique. Here I bring the example of FIA or Imacida or INCIDA, different names, where we can see that in terms of number of clusters, they have a reduced number, and we are small areas and only a few population if we compare to the COMSA system or SIS-COVE system. So these allow us in terms of implementation of of studies and additional service other than or behind the mortality surveillance, the power or enough power to implement other kind of diseases surveillance system or surveys. And using the example of integrated disease surveillance, as I mentioned, and I'll be talking about it later. In terms of data collection, SIS-COVE has a team of community surveillance system, which is based in the community level, and they monitor events daily and usually in each bi-monthly. They need to complete the number of households that are assigned to their area. So each of them have around 300 households to be monitored during this period, and they usually collect events which include pregnancy outcome, and death. So for death, we are able to conduct some specific questions which allow us to identify maternal death, even in terms of registration even. But we also have additional team to conduct verbal and social autopsy. For now, we use 2016 version, but we are in process of transitioning also to the 2022 version, which is new. To be used for the community level, and this is a structure that this questionnaire allow us. So it's divided in terms of neonatal, children, and adults, and they are also able to identify maternal death. Actually, this is exactly to confirm if what a maternal death or not. As you know, after that, we are able to identify the cause of death, and only knowing the cause of death, we can be sure that this was maternal death or at least pregnancy-related death. But we decided to combine, which we call verbal autopsy and social autopsy. So our questionnaire we call VASA, because we also include this component of social autopsy questionnaire to understand more about characteristics at the level of household, housing, and community, and also care-seeking behaviors, including pathway for survivors. In terms of causes of death, we decided to use softwares instead of physician-coded death, which we need a lot of physician, and we don't have it in country, and this will be difficult. So we decided to use automated method, including, for example, here InterVA, in silico VA, EAVA, and also a method which we developed between COMSA and CHAMS to calibrate the cause of death. So we use the CHAMS data to calibrate the system so that we can have more robust results which can be more reliable. In terms of flow, we developed as a real-time data collection system. So this allows us that at the time that the community agent collect event at the community level, because they use smartphone to collect this information. If he has internet connection at that time, the data can be sent immediately to the server. And from the server, we developed a dashboard which help us in two ways. First, for the VA data collectors, because to conduct VA data collector, they need information that is coming from the community, which is being reported by community surveillance agent. And only knowing this information, they can schedule the data to conduct this interview. So they could call the CSA, they can call the household, and after that, they schedule the data to conduct the event. But we also, this allows us also in terms of data management and cleaning. And after that, we developed also a data analysis portal, which is a kind of a portal where we can receive or can have all of the codes we need to run, and so that even personal people without good skills in terms of coding of data analysis, they can run the code and get information shortly. So this allows us to do it quickly and have the results in short time. In terms of profile of data or output from SIS-COVE, so we can get birth profile, death profile, mortality rates on causes of death, and also determinants of death, including social components. So for the determination, we usually have a different level, including the national level, using the Minister, Council of Ministers to be presented. So we did that last year to present and discuss the results at the level of ministers, so that the results can be used to influence the politics, but also official dissemination events, which we usually conduct when we have new report or new results to be presented. But we also developed or conduct provincial level dissemination activity, including multi-sectorial roundtable and programmatic meeting, and also for the community level, using the community surveillance agent at the provincial level, we share the results, and they can share these results at the community level and discuss locally, so that the results can be used to influence the politics. So the data, the COMSA data or SIS-COVE data is being used to increase in terms of general literacy and also policy decision making. In Mozambique, we have strategic plan being used for the health sectors. For now, we still use the one from 2014 to 2019, actually was extended to 2024. And this year, 2025, we have a new strategy where the COMSA data or GHS data was used to develop or to inform the development of this strategic plan and to be used. Since 2023, we have received a lot of contact from other countries trying to implement a simple sample registration system. And we have been doing that. We received different delegations in 2024, for example, we received 3 delegations coming from 2 countries, Nigeria and Zambia, to learn from us how they can implement their mortality surveillance system, and we shared our experience. Actually, and now most of African countries are also trying to implement simple registration system, and we have been in different meetings to present and share our experience, our knowledge in terms of how we implement, develop and implement the mortality surveillance system, and so that they can use that as example for their activity. We also want SIS-COVE to be part of the civil registration system. As I mentioned it before, only 10% or sometimes below 10% of deaths have been covered by the civil registration system. And we think that SIS-COVE or COMSA, with this power, this capacity, can also help them to increase in terms of coverage. So we implemented a pilot of civil registration system. This was the integration of civil registration system under the COMSA in one of the provinces of Mozambique. In terms of results, we have increased a lot in terms of registration, because our community surveillance and our VA data collector helps in terms of data collection and registration of birth and death. So this helped a lot in terms of registration and civil registration. So after that, we decided to develop or put in place an MOU with Minister of Justice, so that can be organized, though we can have interoperability between these 2 systems. So we also developed a new model under the GHS platform, which is the main system for the Minister of Health in terms of data access, so that mortality data coming from the community can be accessed by using this platform. And we also use COMSA as a proof of concept that can be disease surveillance can be implemented, and we use that for implementation of serious surveillance in one province. I will talk a little bit again later about it. So this is the moment when was signed the MOU between CRVS and INS, so that SIS-COVE can officially feed the CRVS, and we can get access to data between these 2 steps. So this page, in terms of interoperability between SIS-COVE and DHIS2, so that people can access directly the information of SIS-COVE or community surveillance system from the DHIS2 or health and monitoring information system.
Also,
Um,
sorry to remind, you can conclude your presentation in next couple of minutes, please.
Okay, so just a few minutes. So in terms of using SIS-COVE also for disease surveillance, we also use it to monitor cholera outbreak in many provinces, and we have been generating these maps bi-weekly so that this can be used for decision making. I also talked about integrated disease surveillance using serial surveillance, and this is results that we can provide or we could provide using COMSA in one of province, and we are now planning to extend this for at least 2 additional provinces so that we can monitor results of integrated disease surveillance and using Luminex. So SIS-COVE is also being basic plan for basic platform for integrated disease surveillance. As I mentioned, this is being implemented as a concept in Mozambique, which include wastewater surveillance, internet surveillance, and genomic surveillance. But community surveillance is being used as a base, and for that, we combine all of the results in the triangulation that can best inform for the results. So in terms of lesson learned and challenges we can bring here in terms of financial surveillance and health system strengthening is not a priority in most of African countries, and Mozambique is not out of that. And usually the fund is verticalized and focusing on specific disease, which makes it challenging when we talk about a broader system like mortality surveillance. So in terms of human resource, it's important to improve in terms of investment in healthcare for community worker and capacity building, while also collaboration between different institutions and other countries is important to strengthen the surveillance system, and also try to make more sustainable the system by leveraging for implementing additional surveys or surveillance. So with that, this is what I can say and summarize it from COMSA and SIS-COVE, and say again, thank you for IANPHI Africa, for IANPHI for this recognizing of success. Thank you.
Thank you so much, Celso, for that wonderful presentation. And definitely, we all congratulate you for having such an exquisite system. And IANPHI also remains indebted for a wonderful event, the annual conference that you recently held in Mozambique. So thank you so much. Ladies and gentlemen, we'll definitely be moving on to some burning questions towards the end of 4 presentations. With that, I would like to invite our next speaker, Jia Lee, who's the Director of Division of Global Health Security at the Korean Disease Control and Prevention Agency. She is a registered nurse and obtained her master's from the Emory University, US, and her focus will be on Global Health Security Coordination Office and its expanding partnerships. But may I request, sorry, for the clarity, the speakers are supposed to keep their cameras on. Over to you, Jia.
Yes. Can you hear me well?
Yes, yes.
And then, okay, can you see my slide?
Yes.
Okay, yes. I try to open the camera is on, but I need to maybe okay, I can just go on, sorry. So yeah, good morning, good afternoon, good evening, everyone. My name is Jia Lee. I'm the director for the Division of Global Health Security, as well as the head of the Global Health Security Coordination Office. And then I'm so glad to have an opportunity to share how KDCA is contributing in global health security and introducing Global Health Security Coordination Office, GHS. And then we all learned that reactive response from various public health events is no longer enough. We stand at the critical juncture, shifting our focus from merely responding to health emergencies to building robust, sustainable capacities that can prevent, detect, and respond to future threats. The core capacities are based on IHR, such as surveillance systems, laboratory capabilities, well-trained public health workforce, and the ability to rapidly detect and respond to novel outbreaks. To achieve this together, global collaboration and solidarity is very important. KDCA has been known for supporting international organizations such as WHO and International Vaccine Institute. And then since 2022, KDCA has expanded to bilateral ODA project with technical support to the countries with a fragile health system, notably ASEAN, Africa, and Laos, and Mongolia, to strengthen their capacity building of low middle income partners in the field of infectious disease control and prevention, taking advantage of KDCA's expertise. And then lastly, in December 2023, GHS, the Global Health Security Coordination Office, was launched. Then what is the Global Health Security Coordination Office? In the New Seoul Declaration from the GHS ministerial meeting in 2022, the Republic of Korea declared that the Global Health Security Coordination Office will be established in Seoul as a way to sustainable global health security. So then the year later, GHS was launched in Oslo under KDCA in December 2023, utilizing KDCA's infrastructure. The goal of the GHS is to strengthen the global health security through the network, and then connect the domestic international partners in the global picture as the think tank for the health security. And then using peer-to-peer support platform, we try to contribute to the building of sustainable capacities. Then what we do is we operate the education and training center, and we performed joint project with the WHO and international partners, and then published the GHS newsletter, and then supports the GHS activities, and then participate in the international activities to build health security networks. And I would like to talk about the GHS core personnel training program more in detail. This is the hands-on training program for core public health personnel of ASEAN 10 members. The purpose of the program is to strengthening infectious disease capacity through intensive practical training with the KDCA experts. 4 areas of courses are provided based on KDCA's expertise: laboratory diagnosis and analysis, and surveillance and risk assessment, epidemiology, and biosafety. But in 2024, mainly laboratory diagnosis and analysis courses were conducted. And these are the pictures of the training program with the 2 completion ceremonies, one in June and the other in October. And then the program pictures. And then total 20 trainees from the 9 countries completed in 2024. And I would like to share our trainees' feedbacks. And then people say the program was intensive, but most of the trainees were satisfied with it because it's more like practical. And I personally like the comment that trainee from the Indonesia. I just want to quote some of them. And he said he became a chief for the National Health Biology Laboratory recently. And then it was very impressive that he can explore collaborative activities with KDCA and then continue to share information and the experience with the KDCA. And then I like this because I hope we all take this opportunity to support and collaborate each other. And this year, 2025, we are now having 15 trainees from 6 countries from ASEAN for the 3rd GHS core personnel training program. Then collaboration. So GHS is working closely with the other international partners and experts and willing to expand further. Actually, we actively participate in the JEE and then connecting Korean experts and then other international experts to the various missions in the globe. Also, we support the GHSA. Actually, KTCA has been with the GHSA since the beginning as a leader of the immunization action package. And I would like to mention here today, the GHS is planning to have a workshop in collaboration with the US CDC and IANPHI in Seoul in 2 weeks under the title of the From Data to Action, Enhancing Data Systems and Integrated Surveillance. And there will be more than 10 countries in ASEAN and WIPRO region are invited to Seoul for 2.5 days workshop to share their experiences and identify the next steps and discuss what we can do together at regional level. So I'm so glad that IANPHI has our partners. So our story is shared with the GHS newsletter. This quarterly published newsletter is consisting of GHS updates with the GHS activities and global updates with the global news and partner stories. You can check the GHS newsletter at our the website, or I think you are currently receiving the newsletter via the IANPHI Secretariat, but you can visit the GHS website and request for the subscription too. So this is my last one. And global health security is a shared responsibility that cannot be achieved by a single actor or sector of a government. We all agree this. And this is a phrase that I would like to share with you today. Building a coordinated response system based on IHR and collaboration with partners enable faster and more effective action during infectious disease crisis, I think. Ultimately, such cooperation serves as a foundation for protecting health and safety of people. So thank you very much for your attention. Thank you.
Thank you so much, Gia, for a wonderful presentation. It talks volumes about your coordination center for global health security that you have established in Korea. And I still remember within a couple of years, it has really evolved as a regional hub, and we hope that as we move on, it will be more international, collaborating with much more partners beyond what you have mentioned. But great presentation. Thank you so much. Dear participants, with that, we move on to our next speaker, Professor Otto Helf, who is a PhD, a specialist in pediatric infectious diseases and specialist in public health as well. He's currently the Director of Department of Public Health at the Finnish Institute of Health and Welfare. And his presentation would be focusing upon One Health approach to managing avian influenza outbreaks on fur farms. Professor Otto Helf, over to you.
Thank you so much. Thank you very much for the possibility to present our the incident that we've had in Finland a year before. And now, unfortunately, this is the holiday season in Finland as well, and I'm not at the office, so I have very narrow bandwidth, and I will also close my video while presenting. Just a second. And just make sure, Chair, are you seeing my slides? Can you see my slides?
Yes, we can.
Excellent. Thank you. So I'm going to talk to you about the fur farm influenza outbreak that we had in Finland. And just to start off, I will show you the epidemic. Resolve to Save Lives did a webpage on the Finnish avian influenza outbreak epidemics that didn't happen. So if you have a beautiful outline, and if you go to their website, you will see a very nice presentation on the entity. Now, I find zoonosis to be extremely fascinating. The mechanisms of from being able to infect animals to the stage of transmitting between humans and meanwhile maintaining the potential to cause a disease are very complex. You add the fact that new transmission mechanisms are constantly developing at each step, you can't be but amazed. How one thing even more interesting and complex than the intricate working of the influenza virus, its complexity in trying to contain it, especially in fur. Just like factor can health security for itself. So it's an intricate interface concerning animal health and human health is immense. And if you add to the mixture the spice of fur trade, in which animal health is not related to food production, you really have a
Otto, apologies, we are unable to hear you right now.
Otto,
Hello.
can you hear us?
Otto, can you hear us? We can't hear you.
I think he has left. Yeah, maybe
Yeah.
we can move on to the next speaker and then see if he's reconnecting.
Right. See if he's joining, then we can take him back. But if he's not, then we can move on.
Yeah, I think we can move on with
All right.
it with Bernardo, and then we will go
Right.
back
Thank
to
you.
Otto when he comes back.
All right. So you meanwhile you can email him as well that we are moving on with the next presentation. So apologies, participants. Now there's been a little bit of interruption. We will move on to the next presentation, and Professor Otto will invite him later on. So our next speaker is Dr. Bernardo Hernandez Parado. He's the Dean of Public Health Schools at National Institute of Public Health in Mexico. And his presentation would be focusing on academic reform in public health education. Over to you, Dr. Bernardo.
Thank you very much, Amer. Let me share my screen. Can you see the front of my presentation?
Yes, we can, Bernardo.
Can you see the intro one?
Yes, perfectly.
Okay, perfect. No, thank you very much for this opportunity to share the work that we have done in the Institute of Public Health of Mexico in terms of this academic reform. So what I would like to do today is give you first some background about the Institute of Public Health of Mexico and the School of Public Health of Mexico. The school is hosted in the National Institute of Public Health, and well, it includes a diverse community of health professionals, researchers, students. We have doctoral degrees, master's degrees, and specializations, some of them more oriented to research and some of them more oriented to the practice of public health. We also have a strong continuous education program, and the school will have both national and international accreditations, including an accreditation from the Council for Education of Public Health from the United States. The School of Public Health of Mexico has become a great resource for training of professionals in Mexico and Latin America. And actually, most of our graduates can get into the public health market without any problem. A bit of context, there are some changes going on in the Mexican health system. There has been a big change in the Mexican health profile, moving more in this transition, moving along to more presence of non-communicable diseases, but still with some infectious diseases present. And the government is implementing a new health system that gives emphasis to primary health care. This poses the needs for new health context and model, because now we realize that it's different, that is the health personnel has to meet new different competencies to operate the new health method. And also it's necessary to develop research and evaluation to guide appropriate health actions. So what have we done in this academic reform? Well, the idea is to put let's say the public health at the center of our work. And over this, we implemented 4 actions that I'm going to describe, including a reorganization of academic bodies, a review of our institutional mission, an update of a normative form, and a renewal of academic program. These changes involve the whole community, have direct impact in research and education, and they aim to give more flexibility and encourage debate and participation of the whole academic community. It's like to make the institution more participative overall. So, starting with the review of our institutional mission, well, we took a look of our previous one, and we identified that it did not include some topics that are crucial, no, like a clear reflection to public health, better reflect the scope of action of our institute, and well, we have been moving along in the many ethical issues at the institute, so it was necessary to reflect and promote a non-discriminatory work in an academic environment. So at the end, our revised mission was discussed with the whole community. We get many ideas. We had seminars to get feedback on this, and we ended up with a statement like the one you see below, no? Having as our mission to contribute to social equity and public health protection through the generation of knowledge, development of health professionals, participation in the design of cross-sector and evidence-based public health, as well as relationships with the community. How do we do it? Well, by using a holistic, humanistic, environmental, and sustainable approach with gender perspective and under the principles of universality of health access, equity, and social justice. So, I mean, more than the statement, and it was very valuable here was the process and the participation of the whole community to try to end up with a mission that reflects our scope of action. Once we review our institutional mission, we started a reorganization of our academic bodies to improve governance. And here again, the idea is to give more flexibility and to open spaces for debate across academic bodies. So new structural academic bodies were developed. The Institute of Public Health includes six health centers, research centers. So we created 6 academic research and education groups that we call for their acronym in Spanish GADIS. And they are in charge of supervising all education and research activities in each of the 6 research centers at the National Institute of Public Health. Then on the right, you can see pretty much the scheme, how these GADIS, these academic research and education groups work. Now, they supervise research teams, so they also supervise academic cloisters. And we also developed 50 research and education groups we call GIDs, because of their acronym in Spanish. And these are research and education groups that work on different topics. Many of them existed before these reorganizations. We try to identify and formalize the existence of these groups. And the idea is that this group conduct research in specific areas of public health, most importantly, integrating students into their activities. And the idea is to, through these research and education groups, to move from individual mentoring of students to a group mentoring of students. Our third action was a review of our graduate academic program. What was the problem here? Well, we need to put public health at the center of academic training in our graduate programs. We were training up to this year people either in our programs oriented to research or to the practice of public health with strong competencies in their specific field, but there was room for improvement in the knowledge of the fundamentals of public health. So we merged our 28 existing graduate programs into 5 major programs: Doctors in Science, Masters in Science, Doctor in Public Health, Masters in Public Health, and a set of specializations in epidemiology, quality of care, and preventive medicine. This restructuring allowed the participation of the students in the research activities by integrating to one of the or more of the research and education groups. And the idea the program is organized is they have to course a core courses set that covers most of the competencies that are required by our accreditation agencies. And then they have the chance to participate in different fields of knowledge with a higher involvement in research and community activities. So we expect the new program, which is starting in September, to be way more flexible and give a chance for students to cover their competencies in public health, but also to explore different fields in a more flexible setting, and also with the chance to participate in a higher degree in research and community activities. And finally, we updated our norms and regulations. All the changes that I have mentioned would not be possible if we don't update our norms. So we needed to formalize this reform to provide an update in the normative framework for our activities, including not only academic procedures, but also non-discrimination, gender, and ethical considerations. And here I would like to emphasize the ethical issues that we are giving a lot of importance at the Institute. Last year, we got the Mexican norms 025 for non-discrimination. This is a voluntary form, but pushes us to implement many non-discriminatory and ethical standards that we must observe. So, what is the relevance of this reform in terms of our performance as a public health institute? I mean, I would like to stress that the spirit of this reform is to put public health at the center of our research, education, and service activities. That we don't lose in the details of specific fields, but we put public health and the essential functions of public health at the center of our work. What are the expected impact of this reform? What do we expect? Well, we try to better meet our mission in 3 ways. No? First, by making our academic programs more adequate to the national context. We were a little bit disconnected. We have to make them more adequate to the new context and the new implementation of the health system. We expect to better respond to the diverse community of INSP and national needs. And finally, we expect to be more efficient. We want to have a more efficient and participative institutional functioning to contribute to a better global health. So, I mean, this is the experience that we are developing now. This is a process. Our revised programs will start in September, so there's still a lot of work. But we are enthusiastic that the community is happy with this proposal. Everybody is contributing to this, and we hope this will help us to better meet our mission. So thanks so much for attending this, and we are open for any comments or questions.
Thank you, Bernardo. That was an excellent presentation, and seeing the integration of various courses. I think we can talk a lot about this during the question and answer session. Thank you so much for that. With that, I will revert back to Professor Otto, if
Thank you.
and you can start from where you unfortunately missed it. Over to you, Professor Otto.
Thank you so much. I will not attempt to put on the video camera. Thank you so much, and I apologize for the mishap with the Wi-Fi. So in Finland, in June 2023, a mink at a small fur farm in the West Coast area was tested positive for avian flu, followed by excess mortality in fur animals on tens of farms. We saw almost all the phases of zoonotic spread, first from a likely source of wild birds through a number of separate introductions to fur farms, then evolution in the genetic structure of the virus, and eventually transmission between the fur animals themselves. 155 people were exposed to the virus, of which most were fur farmers or those working on fur farms, but also veterinarians. Over 500 separate incidents of exposure were noted, and 400 tests were taken from humans. All tested persons were negative, and close to 500,000 animals on 71 farms were culled, and eventually the epidemic was contained. Next slide, please. Now, the amount of work and resources used to contain the epidemic was enormous. We collaborated closely with the Finnish Food Authority, several ministries, university researchers, fur farmers, veterinarians, and so on. The complexities were abundant. As an example, you're likely all aware of, is that it is difficult to do surveillance when parts of surveillance data concerning animals, in this case, are initially considered trade secrets. So when human health is faced against trade questions, things do become complicated. And again, like in all public health, trust was a key issue, whether it was a question on data sharing or risk awareness. In addition to this, we were also the first country in the world to implement the avian flu vaccination in risk groups. We used tens of millions of euros to compensate farmers for their losses due to culling and to increase biosecurity in the trade. All this, and we're still continuing fur farming. Next slide, please. The one thing about the outbreak that we're still answering questions on is the decision to begin vaccinating. And the reasoning behind the bird flu vaccination campaign was that at that point, we still saw an unstable epidemiological situation. We aim to inhibit transmissions and the evolution of the virus. And in order to implement the vaccinations, we've drafted guidelines with the Finnish Food Authority. Next slide, please. The sector, bird ringers, laboratory personnel handling the avian influenza virus, or samples that may contain the virus, and there were other groups as well. We're still vaccinating risk groups. At the moment, we have around 1,000 people vaccinated with, and somewhat less for the second dose. So this process is still ongoing. Next slide, please. So what have we learned? This. I believe that we as public health experts need to look at health challenges through a wider lens, in this case through One Health and planetary health viewpoints. By locating thousands of pandemic-prone animals, minks, closely together in poorly protected sheds in order to maximize fur production, we are stretching the limits of planetary health. And when we're vaccinating fur farmers and those closely associated with farming in order to continue the fur trade, we really need to ask ourselves why. Is it really the effort and the cost? And if we public health specialists do not see the forest for the trees, then who does? Now, our experience underlines that we need to continue our work with renewed vigor and commitment. So let's learn from our experiences, collaborate even more effectively, and strive for a healthier, more sustainable future. Thank you so much.
Thank you so much, Professor Otto, for the wonderful presentation. Now, time for question and answers. We are open. May I request the participants, if they have any question, they can raise their hand and introduce themselves. They can put on their video as well and ask the question, any pertinent question to the speakers, please. I'm still waiting for any hand, and if you want, you can always write down the question in the chat box. So, Gia, over to you, please.
Yes, I have a question. This is Jelly from the KDCA, and actually, I have a question to Otto about the vaccination. Actually, I know that the fur farms avian influenza is really huge outbreak, and then actually, but the vaccination is really hard to persuade to the public. So do you have any how do you guys communicate with the public, or do you have any kind of communication strategy for that, kind of having them vaccinate, or is there any or challenges or something like that to share with us? Over.
Dear Chair, thank you so much for the question. Is it okay if I reply directly?
Yeah.
Right, you really hit the nail on the. It really hits the nail on the spot, because this is exactly the issues that we were tackling with. Finland was the first country in the world to implement this vaccination, and it was targeted to a population that is really, the fur trade industry is rather difficult to reach. It's not part of any larger trade group, so this means that there are complications in reaching out to that public or to that group. And these are experiences that we've actually collected now after the first round of vaccines, and the problems were as expected. It is the small niche group of trade that is difficult to reach, and this is something that we're trying to take into account this time that we're reintroducing vaccinations, in trying to reach those target groups in a more localized manner. So the local workers within the industry will be reached out by the well-being service counties in order to reach a better vaccination coverage in those groups. At the moment, vaccination coverage is really low. Thank you very much for the question. It is a very relevant question.
Thank you so much, Gia and Otto. Rafael, I would invite you for your question to Gia.
Hi, Amer. Thank you very much. Yeah, I had a question for Gia. I wanted to know, how do you select the trainees for your traineeship program?
Actually, yes. We will cooperate with the ASEAN Secretariat and then some Ministry of Health of each countries, and then actually we kind of having some inclusion criteria based on their major, the education and their work experiences and the years of expertise and stuff like that. And then when we send our inclusion criteria for the public health personnel, and then actually the Ministry of Health and the ASEAN Secretariat together kind of select the candidate. And then when we get the candidate from them, and then we can our KTCA relevant related staff, and then the division staff, and then they select the trainees based on the level of the division provided to the trainees. So we all cooperate to kind of selection process.
Thank you, Gia. More questions we do expect from the participants, but meanwhile, I continue, Gia, till the time we have more questions for the speakers. You are dishing out a newsletter. You showed that. That's really wonderful and a remarkable job. what are you doing for the larger circulation of this newsletter? I mean, right now, you seem to be more confined to your region, but how do you foresee larger circulation for this newsletter? Because this seems to be very informative.
Thank you very much. We'll try to reach out the GHSA member, GHSA, the Global Health Security Agenda member, which is like more than 78 countries. And then we'll try to reach out them, and then we'll try to send them to our international partners. Actually, the KDCA, the resources in the network. So yeah, definitely, yeah, we'll try to kind of reach out, and so that's why we asked the IANPHI secretary to disseminate our newsletter to the IANPHI members. So we're trying to kind of expand and then reach out more people to get our newsletter. And then when you come to visit the GHSCO newsletter, GHSCO website, and then there's a kind of subscribe sections, and you can just kind of having some subscription that, so hopefully many people can get to know about the GHSCO and then what we do. So yeah.
Right. That sounds great, definitely, and I think it would be great using IANPHI platform as well for larger an improvement in circulation to different NPHIs who are directly involved. So thank you so much for that. Another question is that you mentioned about the e-learning courses. Are these confined to the members of GHSA, or they are open source? Anyone from anywhere can attain these e-courses online?
Actually, this is our third program, and then we'll kind of improve our program. And the e-learning program is more like action plan making, developing the stuff, because during the COVID-19 we had some kind of lecture style before, so we try to use them to be our training beforehand, the e-learning process. But if it's a long classes, then the people can get bored about it, like the online program. So we're trying to get a shorter term of more like focused on the action plan development. So after the trainees get completed the classes, and they can get to how they can improve or apply their knowledge that can get from our program to apply to their country, and then their expertise. So yeah, we'll try to use the e-learning platform, but still working on it, or maybe still improving. But we'll focus on the action plan development. That's it.
Thank you, Jia. Thank you so much for answering all those questions. Still waiting for any question from the participant. So I will revert back to Celso and ask him a question that, I mean, you mentioned about a very exquisite system that is now functional in Mozambique. So how comfortable you feel now with launching of an establishment of this system over there with the Ministry of Health?
Thank you, Professor, for the question. I think it's a really important question. Yeah, I cannot say exactly that we are uncomfortable, but I can share some of our experience during this implementation. All that when the process started, it was really challenging to get them involved on that, because as you know, there are also ongoing activities and system being implemented by the Ministry of Health, and the technology on the methods that we propose to use are not well known. So the verbal autopsy is some kind of new process in most of this country, and in Mozambique as well. So we had to fight with them to teach them that this is really an important system, and this kind of results are not only implemented, or this kind of methods are not only implemented in Mozambique, but in other countries as well. In most of African countries, this is the only way that we can continue identifying the causes of death of most of death which occurred outside of health facilities. So the challenge actually is related to the funding, which we can say that now we are quite more comfortable, but because as we are generating results, it's becoming easy to discuss with partners, with stakeholders about the system. But when we started, it was really challenging because no one knew about it. So we had to talk about something that no one knew about. But now we can talk about something that everyone sees in terms of results we are projecting. And as I mentioned it, there are also additional countries trying to contact us so that we can explain and advise them in how we can how they can best implement this system. So I think this is only thing that I can say now. Thank you.
Right. Thank you so much for that. My next question is to Professor Otto. You did mention about the Institute of Occupational Health, and under such condition as circumstances, definitely it becomes impossible for a single institute to deal at the national level. So what were your conclusion and your observations, and what would you suggest in such situation, the role of institutes for occupational health? Over to you.
Right. Thank you very much for a very, very important question. Now, in our setting, the Institute for Occupational Health has responsibility over occupational health for safety issues related to occupational health. And in our outbreak, in the fur farm outbreak, the personal protection equipment is under the guidance of the Occupational Health Institute. Now, the problem, of course, is that the working conditions in fur farms are not easy it is not easily possible to comply with the guidance for personal protection equipment. And in order to get that guidance to work, you really need to include both the fur farmers, but also the human health side with the occupational health entity to be able to draft guidelines that are implementable in that surrounding. So in my regard, the collaboration here, there's no single entity that would be okay not to collaborate, or it would not be necessary to collaborate with several different players in such a complex situation as an outbreak on an animal farm that has human health security interests. So thank you very much for a question. It really is dependent on collaboration, just like the presenter previous to me said. Thank you.
Thank you so much, Professor Otto. I'm still waiting for participant questions, so I'll move on to Dr. Bernardo. And I think you have talked very well about transition from the individual to the group mentoring of students. I think that's a great model because this can really transform groups, and those groups can in turn work well with other groups, sort of as a sort of master trainers. So how would you conclude, or how would you share your experience with this sort of mentoring at coming down to the national level, moving on to the global to international level?
Thank you very much, Dr. Akram. Actually, I mean, the way we work now is very traditional. Like, students get assigned to a mentor who is like somebody who has contact and directs many of the academic decisions, and also serves many times as a director of the thesis, or somebody else directs the thesis. But the process is very individualized. And in a way, we don't want to lose that, but we also want students like to have more collaborative work in our research and education groups, participate in projects. And well, the nature of the research projects is more conducted by a group of researchers more than an individual. So our hope is that this will like expose students to different opinions, to different people in the research group, and better train them to participate in research group in the futures by participating in meetings and decisions of the group, and then in a way get mentoring from different persons while they may still have one assigned as the main contact, but be exposed to different opinions in the group. No? So that's pretty much what we want to do. Students will have some sort of shopping period when they start the program, like to interact with different groups, because, well, when they enter, they don't know anything. So, or they may know something, but not that much. So they have like a shopping period, and starting the second semester, they will start working closely with a research group and receive this group mentoring.
Thank you. And that's really wonderful. But talking in terms of how many international students do you get with your academic sessions?
Well, overall, each year we receive about it should be like 200 new students, and we receive mostly foreign students for our doctoral and masters in science program. And there we should have like about 20. So it's like 10% overall, but they are concentrated more in the masters in science and doctoral programs. Many of them come from Latin America, but I think we would be more than happy to receive students from other places of the world as well.
That's really sounds great. We have a raised hand. Over to you, Mary.
Yes. So thank you everyone for the presentation. I just wanted to ask to Dr. Bernardo, do you think that the reform that you worked on, it was easier to put in place and to implement because the School of Public Health was already part of the NPHI? Or do you think there is a link between those two? And do you think it would be possible if there wasn't a link between the school and the Public Health Institute to do the same kind of reform?
Thanks, Marie. No, you're totally right. This would have been impossible to do if the school were not within the Institute of Public Health, because that is what allows the interaction between research, community work, and education. So that I think having the School of Public Health of Mexico nested within the Institute of Public Health is what allows us to move into this direction. No? And by the way, let me tell you that this recognition was a big boost for our reform. When the community heard about it, it was like a big applause, and everybody felt happy as a recognition that it's a big effort, but we were moving in the right direction.
Thank you, Dr. Bernardo. As I see no more questions in the chat box or raised hand, I think I would like to extend a deep gratitude to the panelists, our elite speakers from different parts of the world, and bringing their experience back to us, to ANPHI, and to our dear participants. Equally grateful to the participants for attending this session, and would also like to thank our ANPHI Secretariat staff for making this event possible. Congratulations to the speakers and their institutes and their countries in turn for their success. And we are sure they will keep adding to not only to their countries, but moving on to the regional level and the global level. And that's what the aim of IANPHI is. I want to assure that the recording and slides will be made available on the IANPHI website very soon. And yet another thing, today's session also marks the official launch of 2025 calls for applications. And we encourage all of you to consider sharing your success stories for the next year. And IANPHI Secretariat will be sending an email for providing the details to all the members shortly. And you can submit by September 5th, 2025. So I think that's again yet another opportunity. All the winners, they can do it again for different projects. But we would also encourage all other members to participate actively, as it's a great opportunity of recognition of their contributions to the public health. So thank you once again for joining us. Let's continue to foster innovation, share knowledge, and amplify the impact of our collective public health efforts. We look forward to an engaging and insightful sessions in future with you as well. So thank you so much. Have a good day. Thank you. Bye-bye.
Thank you very much,
Thank
Hammer.
you.
Have a nice day.
Bye-bye.
Bye.
Thank you.